Good morning, good afternoon, good evening, dear colleagues from all over the world. You are welcome to the European Society of Intensive Care Medicine, and today is an important day as we are delighted to welcome Professor Elisa Estenssoro. Professor Elisa Estenssoro is a professor of critical care, and she is in La Plata, which is in the region of Buenos Aires in Argentina. And we are welcoming your questions as they are going to be transferred to Professor Estenssoro. And the first question coming from the audience, Elisa, is a very important one, is how is the COVID-19 doing in South America and specifically in Argentina?
Well, first of all, thank you, Élie, very much for this invitation. And we could say that not very different from other parts of the world. We are now in the middle of a third wave, and which luckily has not been so deadly as the previous one. And in 2020, we had a very delayed first wave, you see, because in Argentina, lockdown was very rapidly established in March, because we're all receiving, March 2020, we're all receiving all this communication, especially from the European Society of our European friends, especially from Italy and Spain. So we know what was coming. And in that sense, the government acted very rapidly. They established a lockdown that was very much criticized from the political point of view. We could speak of that days. But the thing is that it gave us time, we gave us time to the intensivists, because the government could buy ventilators, all kinds of devices, you see, and personal portable equipment. And during this time, this was, I would say, provided. And well, really, we looked at the other countries, our neighbors, and really they had the first wave before us. In Chile, Ecuador, even in Brazil, they had their first waves in, I would say, April, May, and ours occurred in August and September. So, in a way, well, as I told you, there was no lack of all kinds of equipment, but personal health workers, of course, they were scarce. Because as in any other parts of the world, there are no many physicians that are interested in critical care, no many nurses. So there was this intention from the government to have all these people to name or to permit the admission of these people to the health system. But the thing was that there were no available physicians, as happened all around the world. So other specialists were or began to work in the ICU, especially cardiologists, internal medicine specialists. So we had really a problem of scarcity of human resources, not original, because this happened everywhere.
As you say, Elisa, you describe a situation that was indeed the same in many countries in Europe and elsewhere in the world. You refer to a very important event that was the ESICM COVID-19 webinar, and this marathon was a wonderful opportunity to train 15 to 18,000 people and allow them to understand better how we can manage a surge and how we can deal with such a pandemic. When we did the COVID-19 marathon, most of the topic was about healthcare providers. How are doing your nurses and your doctors in Argentina?
In what sense?
They have been facing so difficult events that elsewhere in the world, in Europe, yes, in the United States and Canada and elsewhere, we report a larger prevalence of burnout, of symptoms of anxiety, depression, insomnia. Is it the same in your experience?
Of course. And I tell you something, there's another difference which makes things worse here. Really, the salaries are very low. The salaries for health personnel in general are very low. And this doesn't occur in other countries. For example, in Uruguay, in Chile, in Brazil, this doesn't happen. So apart from the burnout, the people that die, that get sick, which was very frequent, and the indifference of the society, because there was this feeling of isolation too. No, we are working in the ICU. We are risking our lives, the lives of our families in the first wave, and the society didn't want to take care of themselves. They didn't recognize the problem as such, you see. So this was a kind of, depersonalization, no, because or a dissociation, no, the feeling of dissociation between the ICU workers or the health workers in general and the rest of the society. That was very painful. So during the first wave, there were no vaccines, remember, no, nobody knew well what was going to happen. And we had prolonged periods of isolation of all contacts, 2 weeks. So the personnel working in the ICU became extremely scarce, you see? So there were few to begin. Many got sick. Many had to be in isolation for having had contacts, as I told you, 2 weeks isolation. So the rest that remained in the ICU really had the biggest burden of their lives. And some left the specialty. Most remained really, but some left. And some are still with problems, psychological problems, have the intention to return to the specialty, but still can't, you see, because this only did not happen in the ICU. There were, I would say, different hospitals around, how can I say, they were called unities of prompt attention. That was the name. So, but there were ventilated patients there, you see. So there were some doctors that stayed there in these unities that couldn't be replaced because they have no possibility, nobody could replace them, and stayed there, hours and hours and hours, being looking at terribly sick patients and looking at terribly sick patients that died. So this burden of seeing so many people died was so stressing.
Yeah, I think you are pointing out a very important thing about the environment that makes that an ICU bed has nurses, has doctors, and has specialists in the delivery of critical care, making that we can really train people to better cope with delivering critical care. Professor Estenssoro, I have another important question for you. You are a worldwide expert. You are a leading professor, and you're a woman. And my question for you is, how is it to be a so important person, a professor of critical care as a woman in South America? What is your experience? I have read with so much interest the paper that was published on you in the Lancet Respiratory Medicine. Can you tell us more about this experience and everything that you transferred to us in this publication?
Well, the thing is, it's different to be a woman now than to be a woman, a physician in critical care or in any other field, 20 years ago or 25 years ago. But I must say that I know I was always so convinced of what I was doing that I didn't take care of gender, but gender issues existed. And now I see that now that we are more aware of this, now I see things that we've been exposed to and that we take it for granted, you see. Now young physicians are different, young female physicians, and that's okay, that's good. I was used to be the one and only woman in a group of, 20 male physicians, you see, especially internationally. And sometimes, well, it was a bit difficult, you see.
Now our teams are increasingly diverse, increasingly balanced, and we are having more women than men in medicine, and as much as women as men in critical care. So what's your message for the young professionals from every part of the world, every gender? What is your message? What is your positive and optimist message for them for the future?
Oh, well, for all, not only for me, for female or for female physicians. What are you saying?
For female physicians and for female physicians in critical care.
I tell you something before my optimistic measure. We did a study on gender in Argentina in critical care, And what we found, it was a transversal study. And what we found was that only 18% of the critical care, the ICU directors were women. 18%. But on-duty physicians and residents were more than 50% women. So, no, the how to say, the glass ceiling will break, I think, no, because there is and another thing we noticed, and it is so gendered marked, is that the best paid jobs, which are in the private medicine, all those, or nearly all those critical care medical directors are men, you see? So most directors and most bosses are men, I would say, and of them, and most well-paid jobs are men in them. So I hope that this will change. I'm sure this will change, because this is connected to something the young generations of female physicians have, and of female professionals have, is this awareness of the gender bias. So that is my message, just to be conscious about this. No, you don't need, or we have not to naturalize all these differences.
And this message applies to everyone, whatever the gender. Thank you very much, Elisa. No, please carry on, please.
Sorry?
No, I was asking, the third question is about you are very much involved in research, and you are a dedicated investigator in many domains of research. You have been sitting in editorial boards. So what are currently in South America and in Argentina the most important topics of critical care research that are either in published studies or in things that are currently ongoing in your region?
Well, we would say that you know the Living Network, no, which is a network of intensivists all over Latin America that has published a very important study on resuscitation of shock, which is the Andromeda study, in which we tested the capital refill time as a way of following and of evaluating and also of treating patients with septic shock. So now a similar study, although not similar, but the second study, which is the Andromeda 2, is being developed. I think we'll begin to recruit patients soon. The director of this is Dr. Guillermo Hernandez from Chile, and this study tries to discern a question that is so discussed now. Is a tailored approach, no, to patients with septic shock in diagnostic and also in treatment is better, is associated with better outcomes than the usual approach. So I think that is of Latin America, that is the most important project. But of course, there are very important groups in Brazil, which are led by Flavia Machado, by Carmen Barbas, by Alex Viasi-Cambalcal, and of course with Marcelo Mato, that had an important lines on mechanical ventilation and of course on sepsis and shock. And so these groups are always producing breakthrough studies, no? So they have just produced this study on fluids. So I think that these are the most important lines in Latin America. They are connected with sepsis, shock, and mechanical ventilation.
Well, these are very important and hot topics in critical care, and we have been so impressed by the number of publications coming out, and high-level publications coming out on COVID-19, and within a few months you were able to reorganize and to give priority to these big studies, and we have been in total admiration for that. Elisa, as you know, we are very interested, and I know that this is also one of your interests, about cross-cultural variability. and we live in different countries, and inside Europe it's very diverse, and I'm sure that it's also different between Argentina and Europe. It's about the patient-physician relationship with family members, information, communication, as well as the management of patients at the end of life. Do you have specific rules, specific laws about these points in Argentina? And do you know whether there are some specific differences throughout South America?
Well, in South America, the project Humanizing the ICU from Gabriel Eras was very important, and people adhered to these recommendations. And in this way, during the first COVID wave, there was a kind of, as in everywhere in the world, there was this kind of anguish because of the lack of communication between patients and families. And soon there were many ICUs that started to develop some kind of permitting families and to communicate with patients. So unusual for the moment, unusual to develop just to use the tablets in the ICU or the telephone that weren't used before. And there was a facilitation of doctors. Doctors were terribly busy. Notwithstanding this, they made their time to enhance communication with patients and families that had been living through such a terrible period. So, and this was so. I would say it was such a change during the first wave that it also appeared in the press, in the newspapers, that a different approach to patients with COVID that were admitted to the ICU, and this was very, I would say, very relevant. It took a lot of time, but nobody complained of this. This is the feeling that this was good for everyone.
Of course, and I believe that for the next generation and for being attractive in our specialty, I think that these human aspects are also very appealing because we manage to deal with them. We don't undermine the time and the skills that are needed to better speak with family members, to involve them on a daily basis in whatever decision, and sometimes in the care that we are providing to the critically ill. Mm-hmm. With regard to end of life, do you have a specific law in Argentina that, because as you know, in Europe and as well as in the United States and North America, there are parts of regions where there are laws that really cover euthanasia, assisted suicide, and is it the case in Argentina or in South America, or are we in a classic model?
I don't know about other countries, but we don't have a law of euthanasia. We have a law regarding advanced directives, but not that, you see. And these were things that were very much discussed during the pandemic. Not euthanasia by itself, but this thing of the last bed, what to do if you don't have enough resources, who to prioritize, and there was a lot of discussion about this in the society.
Thank you, Elisa. I have another question that is related to the free movement of ICU specialists inside South America. As you know, the European Society is promoting the fact that we should have more freedom to work inside the Europe, and the ICU specialist should be recognized as an entire specialty, as to have this free movement. So whatever the base specialty, whatever it is, whatever is the model in every country, if the ICU specialists have the training and the competencies, they could move as they want inside Europe to help and to work and to learn and to be ICU specialists. But for that to happen, we need to have intensive care recognized as a specialty in the Annex 5 here in Europe. How is it in South America? Can you, for example, hire, if you're in a surge related to a pandemic, can you hire colleagues from other countries from South America? Can they come and work immediately in Argentina, or are there specific rules regarding that?
The specific rules are especially for the medical profession, you see. And that is very, I would say that's very rigid, you know, the laws take big care of this. But having said this, usually there is an acceptance of other specialists, you see, especially if if this specialty is being issued by a university, you see, because we can have the title of critical care is a specialist here in Argentina, and the title can be issued by the College of Physicians or by the university or by the scientific societies. But all these are accepted. But from someone that came from abroad, if he or she has a title issued by university, it is a national university, it is accepted as and the reverse is also true. Many people from other countries come here to Argentina and do the course of specialization course of critical care. And if they have the title issued by the national university, where they can work in their respective countries. We have many physicians from Colombia, from Ecuador, and from Bolivia. Not only
Colombia, Ecuador, and Bolivia.
Yes, and also from Peru, and they come not only for critical care, but for other specialists too, surgery, infectology, but many surgeons come here to be trained in Argentina.
Yeah, and I agree with that. I think that an ICU specialist is a specialist that can deliver the best of intensive care medicine, whatever is the background, only if the people have the right training and the specifications. I think that they should be able to move and to have the freedom to work everywhere inside the European community. And this is, so we hope to have the same than what you have. Elisa, I have a question about how ICUs are structured. Do you have a 24-hour coverage in the ICUs? Do you have a specialist at night in your ICUs, or are they on call? Do you have residents and interns at night? How are the ICUs in Argentina organized?
Well, they are they are on duty 24 hours. And now we are trying to evolve to 12 hours, but always with full coverage, you see, because it is assumed that, and it's true that the 24-hour span really produces, I know, in a long time burnout, but people began being tired of the specialty. So there's this movement towards the duty of 12 hours, but we have full-time intensivists there. Now that's our main organizational structure. And
this is all over the country?
Yes. The thing is that in some, I would say, some provinces, there are no enough specialists, and someone, perhaps an internal medicine specialist or cardiologist, makes all this coverage.
That's a very important point. Elisa, for the future, so we have to develop a specialty that will be attractive for the next generation of doctors and the next generation of nurses. And we know that the pandemic didn't really target, but I think that it actually really was the click and the way for people to be aware that they were working in difficult conditions, and now we are having closed ICU beds and closed hospital beds quite everywhere because of the nurse shortage. And I've been reading a paper from 1928 published in JAMA about the nurse shortage. That is not something really new. Do you have specific requirements, or do you have new things that you are developing in Argentina to maintain your human resources, to have your nurses staying in the ICUs and your doctors coming to ICU and going more into our specialty?
No. Well, I would say, I would like to say that this is politics from the Ministry of Health, but regrettably,
like everywhere, of course,
this doesn't happen. I can tell you what we do. For example, no, and this is directed to students of the career of medicine, because as you know, this specialty is not known. No? Nobody knows about critical care. They know, I'm referring to the students of medicine, or they know it is not, or the knowledge of critical care is not installed in the career of medicine. So what we did was to have an optional subject, which is called critical care. And we started 3 years ago, and there was enthusiasm for from the students. And now the Faculty of Medicine decided that this should be a subject, just not an optional anymore, but as part of the whole career. So we are in that process, and we hope that that can help. What I can say is that this year, for example, more than 200 students wanted to do this subject. So I think in that, yes, perhaps due to the pandemics, now people know about what happens in the ICU. And regarding nurses, well, there's a politics in the Intensive Care Society, the SATI, from, I would say that it has for the last 10 years, no, to have a course that is dictated all over the country of specialization in critical care for nurses. And, you know, many nurses all around the country do it. So that's interesting. So what I can say, there are offerings of knowledge, but really there should be also, I know, a different consideration from the health authorities. We really wanted something different. We thought that after the pandemics, well, we will be considered in a different light. But I don't know if that has happened anywhere in the world. What happened in France? You are just as you were pre-pandemic?
Yeah.
Did anything change?
No, in France, as in many parts of Europe, we are in the same situation. But I would say that you know, patience is what we miss the most. With the pandemic, people are getting more quickly nervous, are more quickly exhausted, and I think that basically they would not accept things that they were accepting before. And this takes us to a question directly related to that, that comes from the chat on how to tackle the workplace stress working in the ICU. Do you have specific ways to reorganize your ICU as to reduce the level of stress? Do you have a screening of burnout? Do you have working groups on that? Do you have more communication inside the team to decrease the burden of the ICU? Is there something specific that you do?
No, really we don't have that kind of activities, and really we regret that. We have tried before the pandemic to have to organize something with the psychologists of the hospital, but they weren't interested. So really, we don't have any specific tool for that. But I can tell you is that I think that it was 4 years ago, a group in the Society of Critical Care made a survey between intensivists, and the level of burnout was high before the pandemic. So guess what happens now?
Yeah, and during the pandemic, the society, ESICM, had a publication on the level of burnout in nurses and doctors, and it was quite high. And we have really this hope that we will be facing a reduction in this level of stress, burnout, and mental health symptoms in healthcare providers. Elisa, maybe one last question for you. And what is your feeling? Do you have a hope that you want to share with us for the delivery of critical care worldwide and for the next generation? What is your main hope? What is your main feeling? What could What could we tell them, to the youngest that are listening to us today?
Well, you know, I'm so enthusiastic about the specialty that
You are.
I am still after 30 years. So what I wish is that I think that this is the best specialty because you have many combinations. You have physiology, if you like physiology. Well, physiology is there. It's what you see every day. And if you want clinical epidemiology, you can do it also. You have so many fields of knowledge that I know it never ends, you see, you never get bored. So that this is what I always tell students of medicine. You are in a specialty that I know it takes into account different diseases, different specialties in medicine. You see everything there, you see. So, and the possibilities of research and of answering important questions that haven't been answered yet are there. So my message is optimistic, and what I feel is that intensivists will take conscious of themselves, of what they mean in the whole society, because the pandemic has shown that. So that is to be, you know, there's in Brazil it started a movement which is the pride of being an intensivist. And this is what I always say, no, I wake up feeling pride of being so, and the same feeling is what I hope to grow in the next generations.
Thank you, Professor Estenssoro. I really share your optimism and your enthusiasm. And we are many convinced that we are working, caring for seriously ill patients, but with an interdisciplinary team. We are working together, and together we are intensive care. Thank you very much.
Yes.
And I admire you, like many of the people in the chat that are sending you all our thanks and all our admiration. Thank you, Elisa.
Thank you. Thank you.
A nice day.
Thank you for the invitations, and my warmest regards to all.
Thank you.
Bye-bye.